Hi, my name is Gregory, and today I want to present another case, one of my cases. It's a one-day smile makeover from 6 to 11, and I used Empress Multi and A2 color. So this patient present to my office with a almost straight bite, and she wants to correct her front teeth. She also have problems with the spacing between her teeth, so I have to manage with it also. But this case, what I'm presenting right now, I want to come from the occlusal point. So many of us we're trying to do, the crowns, laminates, but how sometimes we have to, we might have problems with occlusion. So this patient has a TMJ problem on the left side on opening, and she has deviation towards the left. So she has a clicking, but she doesn't have any symptoms. So the problem is with her that she had the braces in the past, and you can see according to her occlusion, it's she was wearing those upper teeth down. So of course it's not active, but what was the reason probably why she has a TMJ probably in the past? What she had the braces, and her orthodontist when they aligned those teeth, they didn't create the space for the lower jaw to grow. So what happened is she developed what we call a CCP, constricted chewing pattern, and what it does, it means the envelope of motion is right, is normal, but her upper teeth was on the way, and that's why you see the consequences. So what happened is because the jaw was growing, still growing, didn't have enough space, it was pushing the jaw back again. That's why it made the dimple in the joint and create those click sound. The good part, she doesn't have any symptoms. But sometimes what we might probably create the problems when we start touching those front teeth, which would lock the jaw in place. And when we start touching and the lower jaw became free, it might probably shifted and became like a class 3 or something else. So that's why I have to be careful. So that's why I see some posts on a message board, and we have to address it. So this is not like um, like a great case, but I pull this case just to show it. So what I went through, what kind of mistakes did I make, and what can be done probably better. You look in these pictures right now, you can see she has multiple restorations, and she has a big space, big gap between 6 and 7. She has a little bit midline issue, but what's probably the best way to restore those teeth. So facially, when the patient smile, you're not going to see the difference, the huge number 7 and number 6. I made number 8 and 9 in crowns, and the rest of the teeth I put in laminates. If anyone probably trying to develop the case, especially the front is complicated with occlusion, I suggest you to use Panadient Articulate. It's my favorite. You can see this model was on a plate, and you can use this plate as your golden proportion. You can see again the space between 6 and 7 is huge. The 89 a little bit chipped, and again we have to create equal size of those teeth on the final restoration. The penalty, I didn't articulate this case, and what was a problem at the beginning. That's why I didn't give enough information to my lab, enough data, so they can create something nice. Functionally. The another reason is the problem is when we send the laboratory the model, they treat the model itself. I mean, not the patient. So you can see on the next slide, you can see that the wax up was done. Was wax up good? Yes, it's good. But is it functional? It's not. You can see on the wax up, you can see the smaller ridges on the lower teeth in contact with the upper ones. And the porcelain, of course, is going to chip, so it's going to create the same problem. So no matter what you do, if you're not correcting the occlusal problem, it's going to come back to you and bad. Okay, and people pay you money and they're expecting probably something going to last you like forever. So this is a template for me how to prep the teeth, how much the reduction have to make, and what the final restoration is going to look like. So before I start, what I usually do in my office, I apply the wax up and the patient's mouth without prepping them. So I want to see the approval. Do they like the final outcome before I start irreversible procedure? The next, if I got to sign the consent that they like the crowns the way it looks, then I'll proceed. So I will prep first, not final prep, but prep first, breaking the contact points and apply those temporaries back again. And again, I want to see the final approval from the patient. So what she would like probably to change on those crowns, and I see what kind of occlusion I will get. You can see on the picture here, I still don't have enough space for number 9 to cover the lower teeth. Of course, the best probable result here would get with the braces, and I would have less problem. But again, the patient doesn't want to have any braces done. So what can be done to achieve the best result? You can see from the lingual view, adjust the bite, and then I'll start my case. It's a Sarmen technique. I utilize Sarmen technique, and I start with number 8. Why did I start with the front teeth? But I want to make sure I keep the front, the midline in proper positions, number 1, and it's gonna give me the better outcome for the patient. The most people avoid the concentrate. They concentrate on the front teeth. How they look like? They're symmetrical. They don't care about the back ones, but the 2 front teeth are the most important one. That's why I start with those teeth. And also, what most people that making mistakes when they do Sarmen technique, they have to try to adjust this proximal, kind of polish them. So when you scan it, your contact point is going to be smooth and nice. So when you deliver the crowns, you don't have to make so many adjustments of roughness. Okay, the more you prep and prepare those teeth and the crowns, the better outcome and less struggle you're going to have at the final result. So this is the final preparation from different angles. You can see on number 7 I still have a decay, but again I didn't remove it until I will deliver the laminate, and then I remove before deliver the laminate. Then I remove. I don't want to create any undercuts. You can see the day of insertion. Okay, what I did on number 7, number 10, a little bit bulk them up a little bit facially, so the patient will not break the laminates, number 1, and secondly, I adjust her bite a little bit. Okay, that way, so it will, when she functions, she will not break those front teeth. Okay. Let's see another picture. This is 2 weeks after the insertion. You can see the tissue almost healed. But what I do in my office, I take in final pictures 2 weeks after the procedure is done. I want to see where the residue of cement, where the didn't polish well, what the patient complains, what probably can be done better. And I send the patient for the hygiene to remove any residue of cement. But you can see the midline is established. And you can see here in this picture deviation. You can see the midline on upper teeth where it stays, and the midline on the lower, you see it's towards the left. So sometimes you might probably get into trouble if you not be careful. You have to collect the data before you start prepping the teeth, because sometimes it will deviate that way and you won't be able to correct it. And this is 2 weeks after the insertion. You can see I didn't put any stains like details on this patient, but I want to show you this, how did I approach this case. You can see from different angles. You can see even I left the residue cement, but you can see the number 6 and 7 how I covered the spaces. Okay, you can see from left side, you see the residue of cement again. Again, she's gonna see the hygiene, and now I'm gonna do a final polishing on this patient. This is a lingual view, and this is again, it's a close view of those restoration. Thank you very much.